Okay, so today we will discuss tumors of peripheral nervous system, and we will do it in a slightly different way than usual. It won't be a lecture, it won't be a short video, it will be a slide seminar. And we will start with schwannoma or neurinoma, which is a synonym. Schwannoma is a benign tumor. It's a benign lesion that harbors almost no risk of malignant transformation. And it can be found basically anywhere in our body, but usually it's beneath the skin, so the typical localization is superficial rather than deep. And again, you can find it basically anywhere, but quite commonly it is situated in the head and neck region or shoulders. In most of the instances, it stays attached to the small branch of peripheral nerve, included cranial nerves. Quite typical localization is schwannoma of acoustic nerve, if we want to speak about the cranial nerves. From the surgical point of the view, it's quite important that the schwannoma stays attached to the nerve from the lateral side. So it just adheres to the peripheral nerve, it doesn't grow through the nerve, which is different from neurofibroma, which we will describe in a minute. And as I said, this can have some surgical consequences, because if the schwannoma stays attached to the nerve from the lateral side, you can remove it without actually damaging the nerve. But in case of neurofibroma, you need to dissect the nerve, you need to cut away a part of the nerve, because the tumor grows through the nerve. In most of the instances, schwannoma is a sporadic lesion, so it comes in a sporadic way, but sometimes it can be a part of familiar syndromes, typically neurofibromatosis type 2. So sometimes schwannoma can come as a part of neurofibromatosis type 2, and as I mentioned, you can find schwannoma also attached to the cranial nerves, including acoustic nerve, which is quite typical. And if you find the bilateral schwannoma of acoustic nerve, it is almost 100% specific for neurofibromatosis type 2. Of course, nothing is 100% in medicine, but it is very typical, and you can be almost sure that this patient will have neurofibromatosis. And how does it look like? Schwannoma consists of tumor cells that show differentiation towards Schwann cells, hence the name. So the cells looks like, or they are similar to Schwann cells. They are spindle-shaped, elongated, with eosinophilic or little bit pale cytoplasm, and elongated nuclei. The cytoplasm is eosinophilic, however, it's more pale compared to smooth muscle cells, for example. So the cells are spindle-shaped, with eosinophilic or pale cytoplasm and elongated nuclei. Even the nuclei are more elongated, they are sharper compared to nuclei of smooth muscle cells, which are a little bit more blunt. And as you can see, the cells show no atypia, no nuclear irregularities, no hyperchromasia, and there is no increased mitotic activity, which is in keeping of the benign lesion. However, a lot of tumors can look like this. But in schwannoma, you can find a few peculiar structures that are, again, not 100 specific, but they are quite typical for schwannoma. And for that, we need to use the lower magnification, and on lower magnification, you can appreciate those beautiful nodules or curves, which are very typical for schwannoma. As you can see, the schwannoma cells, those elongated cells, they show a tendency to palisade, which means the nuclei of the cells form one line. It looks like a fence or soldiers in a row. So this is called palisading of the nuclei, which is quite typical for schwannoma. And sometimes you can see these structures, which is a nodule or small rosette with the palisading nuclei on the periphery, but in the center you see no nuclei. There are just cellular processes. There is just a neuropil. And these structures are called Verrochi bodies. So Verrochi bodies, it's this structure with the palisading nuclei on the periphery and the pale center, which doesn't contain any nuclei, but there is just a neuropil. This is called Verrochi body, and it's quite typical for schwannoma, and it can help you with the diagnosis. And as you can see in this picture, you can see multiple Verrochi bodies. The tumor consists almost exclusively of Verrochi bodies, and this is a very striking appearance, and I think you need to be very lucky to see this in bioptic practice, because this is a really amazing image. Well, generally speaking, the histological appearance of schwannoma can be subclassified into two categories or two subtypes. First is called Anthony A, and the second is called Anthony B. And Anthony A, that's just what I described. Anthony A is characteristic by presence of nuclear palisading and Verrochi bodies, which means that the Anthony A variant is more typical for schwannoma, more characteristic. Anthony B variant is less characteristic. It usually consists of, for example, it would be something like this region, for example. It consists of the cells that are more haphazardly arranged. There are no nuclear palisading, there are no Verrochi bodies. It's just a haphazard arrangement of the cells, and the stroma of the tumor is quite loose, often myxoid. Which means that this second appearance, this second subtype, this second morphological subtype is less typical. It's less typical, it's more general, and many tumors can look like this. From the clinical point of view, it doesn't matter, because there is no difference in biological behavior, there is no difference in prognosis of those tumors. It's just it's important just for us, for pathologists, because we need to know it to be able to recognize the tumor. But from the clinical point of view, it doesn't matter, and very often you can see the both features in one tumor. So very often it's a combination of those two subtypes. So this is schwannoma. So as I said, elongated spindle cells that resemble Schwann cells, and they often tend to palisade, and the palisading nuclei with the neuropil in the center. This structure is called the Verrochi body, and it's not 100% specific, but it's very typical for schwannoma. And we will stay with schwannoma a little bit longer, because I want to show you one typical feature that you can see in schwannoma very often, and it may confuse you. This is another example of schwannoma. Again, you can see elongated nuclei. Well, sorry for the quality of the image, it's not exactly sharp, but I think we can appreciate the main things. And so again, the elongated cells that form fascicles. Sometimes you can see some sort of palisading of the nuclei. It's not so prominent as it was in the previous picture, but still you can appreciate it in some regions. And also sometimes you can see the pale regions between the palisading nuclei, so some sort of Verrochi bodies can be appreciated here as well, especially on the lower magnification, as you can see it here. But as I said, it's not so striking as in the previous picture. Again, here some sort of palisading of the nuclei with a neuropil in the center. So yeah, you can appreciate those things as well, but as I said, it's not so striking as in the previous picture. Again, in this region and in this region. But I want to show you something different. In many places, you can see the cells that doesn't look nice. They are bigger, they are atypical, with dark nuclei, which are quite hyperchromatic. Sometimes you can see multinucleated cells. It can catch your attention, especially on the lower magnification, because those cells are quite prominent, they are dark, and they just catch your attention. Again here, those bigger atypical cells. Here, also here. So you see that you can see quite a lot of atypical cells with big dark nuclei, and these cells can look quite worrisome. And you could say to yourself, well, this can be some sort of sarcoma, or this can be some sort of malignant peripheral nerve sheath tumor, and it can frighten you. But don't be frightened, these cells are not malignant cells. This is a degenerative change, because in long-standing schwannoma, if the schwannoma is really old, the cells can undergo a degeneration. You can see it focally, but you can see it even diffusely, and the vast majority of the cells can look like this. And the degenerating cell, generally, it doesn't apply only for Schwann cells, but generally, if the cells start to degenerate, it can look very worrisome, because degenerative atypia, as we call them, can be quite striking. So don't be confused, these cells are not malignant, this is just degeneration of the tumor that is quite old. And if you find this in schwannoma, you can call it ancient schwannoma, like old schwannoma. So those ancient changes, it's just a degenerative process in the tumor that is quite old and that stayed for a long time in our body. So don't be afraid of this, this is not malignant. If you applied immunohistochemistry, for example Ki67, those cells would be negative, which means that they are not malignant proliferating cells. They are negative because they don't grow, they just degenerate. So those cells would be negative in keeping with the degenerative process. So don't be confused by those ancient changes. Okay, and let's leave schwannoma and we will move to neurofibroma. Again, it's a benign tumor. It's a benign tumor that differentiates towards peripheral nerve system. It's quite similar to schwannoma, but there are some differences, and some of them are important. Again, it's a benign lesion. Benign lesion, it can be found basically anywhere in our body. Usually it's situated superficially, but it can be also deep-seated. Again, the risk of malignant transformation is very, very low. It's higher in deep-seated lesions, in retroperitoneum, for example, but especially the superficial lesions harbors almost no risk of malignant transformation. It doesn't apply for one special subtype of neurofibroma, which we will describe in a minute, and it's called plexiform neurofibroma. So it's something different, but we will describe it in next slide. But in this slide we can see a classic neurofibroma. So here you can see the skin excision. The skin is covered by epidermis on the surface, which is quite okay. It looks normal. Nothing serious going on here. But the lesion that interests us is here. It's this pale nodule, this pale area. And it's a neurofibroma. Neurofibroma shows some features that are different from schwannoma. Well, first of all, but again, it's usually attached to the small branches of peripheral nerves, but in contrast to schwannoma, and I've already mentioned it, it's not attached from the lateral side to the peripheral nerve. It doesn't just adhere, but it grows through the nerve. So if you want to dissect it, if you want to remove it, you need to cut away a piece of the peripheral nerve. That's the first thing. And second difference is that schwannoma consists of Schwann cells, but neurofibroma consists of basically all components of peripheral nerve. So you would see Schwann cells, you would see fibroblasts, you would see perineural cells, and some remnants of nerve fibers. So that's the difference. Histologically, again, it consists of elongated, spindle-shaped cells, but it contrasts with a eosinophilic cytoplasm. Again, the cytoplasm is more pale compared to smooth muscle cells, for example. But in contrast to Schwann cells, the cells in neurofibroma are a little bit smaller, as you can see it here. They are smaller and they are not so elongated. They are a little bit elongated, but some of them are more oval, let's say, and even the nuclei, they are shorter, more oval. Sometimes they can have an appearance of a tadpole with one end more blunt compared to the other end of the nuclei, of the nucleus. So this tadpole appearance is quite typical for neurofibroma. So we can see the cells are a little bit smaller, they're more oval, but again, there are basically no atypia of the cells, no mitotic activity, no increased mitotic activity. So again, it's a benign lesion. And also the architecture is less typical, less specific compared to schwannoma, because in neurofibroma you don't see verrucai bodies, you don't see nuclear palisading. It's just the haphazard arrangement of the elongated cells. Sometimes it can form fascicles, but very often you see just this population, which just in some regions can form something that looks like fascicles, but in some other regions it's just the haphazard arrangement of the cells. And the stroma is typically quite loose, pale, edematous. It can be myxoid. So generally the morphology of the neurofibroma is less specific, and many tumors can look like this. So this is neurofibroma. As I said, it's usually benign and it's usually sporadic. But again, some examples can come as a part of genetic predisposing syndromes. And in this case, in this situation, it's mainly neurofibromatosis type 1. And the patients with the neurofibromatosis type 1, they often have dozens, hundreds of neurofibromas. You can see multiple nodules beneath their skin, basically all over their bodies. And in these patients, especially these patients, can develop that one special subtype of neurofibroma that I mentioned already, which is a plexiform neurofibroma. And plexiform neurofibroma harbors an increased risk of malignant transformation. So this subtype it can be dangerous. And that's why we should be able to recognize it, because plexiform neurofibroma, it's something different compared to classic neurofibroma. And we can see plexiform neurofibroma here. So this is a typical example. So again, we've got a skin excision, or skin and subcutis. So here you can see adipose tissue of the subcutis. Here is the dermis, and the excision is covered by epidermis on the surface. As you can see, the epidermis is quite okay. Well, there is some sort of hyperpigmentation, and there is a slight acanthosis of the epidermis, but nothing serious is going here. But the tumor is beneath. So this is the tumor, these pale nodules. So these nodules of variable size and shape, these nodules, this is the plexiform neurofibroma. But in reality, they are not nodules. What does it mean, plexiform? Neurofibroma is not the only tumor that can grow in plexiform way or plexiform fashion. There is a lot of tumors that can be plexiform, but for the plexiform neurofibroma, it's quite typical. It's a diagnostic feature of this subtype. And plexiform means that the tumor grows in multiple fibers or multiple strands or channels that forms some sort of 3D meshwork, 3D web. And if you cut this web transversely, you will see this. So these are not nodules, these are not spheres. This is just transversely cut meshwork of the plexiform neurofibroma. So all these regions, this is the tumor. And the histology inside of these so-called nodules, it's basically the same. You can see the neurofibroma. So smaller, elongated, oval or spindle-shaped cells that show basically no cytological atypia, no increased mitotic activity, and the stroma is quite loose, it's edematous, it can be even myxoid. So inside the nodules we can see classic neurofibroma. So the cells are not different, but the architecture is different. So all those nodules, it's just the transversely cut meshwork of the tumor. And it's quite important to be able to recognize this, because as I said, plexiform neurofibroma, this histological subtype is very typical for patients with neurofibromatosis type 1. Again, it doesn't mean that you cannot find this tumor in other patients. It can appear also as a sporadic tumor, but it's very typical, and usually it will appear in patients with neurofibromatosis type 1. And as I said, this particular subtype has an increased risk of malignant transformation. It can transform into malignant peripheral nerve sheath tumor. So it's you need to pay attention for this. In patients with neurofibromatosis type 1, basically 50% of those patients develop malignancy throughout their lives. So let's move to the malignant cases. And you can see it here. This is the example of malignant peripheral nerve sheath tumor, which is a malignant tumor with differentiation towards peripheral nervous system. It used to be called neurofibrosarcoma, and the neurofibrosarcoma is it's easier term to remember, and I think the vast majority of the students and pathologists would prefer a term neurofibrosarcoma compared to malignant peripheral nerve sheath tumor. But it's true that neurofibrosarcoma, the term is not correct, because this is not a sarcoma. This is a tumor with neurogenic differentiation, so it's not a sarcoma. So the malignant peripheral nerve sheath tumor is more accurate, but I understand that the term is quite difficult to remember. So it's a malignant lesion. It's a malignant lesion, and it's a high-grade malignancy. It's a high-grade, very aggressive malignancy. The prognosis is not good. And it can appear de novo, or it can appear as a progression from neurofibroma, especially the plexiform subtype. Progression from schwannoma is exceedingly rare. So usually it's a progression from plexiform neurofibroma, or it can appear de novo. Sometimes you can see a peripheral nerve close to the tumor, but usually these tumors are quite big in the time of diagnosis, and they are big, infiltrative, and you don't see the peripheral nerve from which it originated. How does it look like? The histology of MPNST can be very variable. So usually you need immunohistochemistry. So it can look, the cells can be very variable, the architecture, the style in which the cells grow can be very variable, but usually it's a spindle-shaped malignancy. So usually the cells are spindle-shaped, similar to similar to schwannoma or neurofibroma. So the cells are usually spindle shaped with the eosinophilic cytoplasm, and again the cytoplasm is more pale compared to smooth muscle cells, for example. So the tumor, generally the whole tumor, is more pale compared to leiomyosarcoma, for example, because the cells have a more pale cytoplasm, and so the nuclei are more prominent because of the pale cytoplasm. So usually it's a spindle-shaped tumor, but you can also appreciate signs of malignancy, in contrast to schwannoma, for example. So you can see that the tumor is hypercellular. There's a lot of cells, really a lot of cells, and the cells are atypical. You can see that the nuclei are, very often they are dark, hyperchromatic, they are atypical of various sizes and shapes. So you can see signs of malignancy here. And also, I said it's a high-grade malignancy, so we should be able to find a lot of mitosis. Well, I'm pretty sure that I won't be able to find any during this presentation, but we would definitely find some of them. You know, a lot of those dark nuclei, they are not mitosis, they are just dark nuclei or pycnotic nuclei. So, and especially in this picture, which is not completely sharp, it's difficult to find something that looks like clear mitosis. But I think, at least in some cells, I think it would be a mitosis. But under the microscope, we should be able to see plenty of them. So I don't want to take your time and search for mitosis, but there should be a lot of them. Okay, and you can see that the tumor grows in fascicles. So the fascicular growth is quite typical. Another feature that is quite typical for MPNST is that and you need to appreciate it on lower magnification. I said that the tumor is hypercellular, but the cellularity varies throughout the tumor. So you can see some regions that are less cellular and some regions that are more cellular. So on the lower magnification, you can see regions that are more pale and regions that are more dark. And this, let's say, this biphasic appearance, where you can appreciate the pale areas and areas that are more dark, it's also quite typical for MPNST. But as I said, a lot of tumors can look like this. A lot of sarcomas are just the spindle-shaped sarcomas, and MPNST doesn't need to look like this. The morphology of MPNST can be quite variable. So very often, I would say in the most of the cases, you just need immunohistochemistry to confirm the diagnosis. Sometimes you can see heterologous differentiation. You can see divergent differentiation, which means that in the tumor you can appreciate some regions that contain some other type of sarcoma than MPNST. We don't see it here in this picture, so I will just say it theoretically, but sometimes you can see divergent differentiation. In MPNST, it's usually a rhabdomyosarcoma, which means that a part of the tumor will start to differentiate, it will start to transdifferentiate towards malignant tumor from skeletal muscles. So sometimes you can see regions of rhabdomyosarcoma in MPNST, and again, MPNST is not the only malignant tumor that we know that can transdifferentiate. You can see it in many other malignant tumors. You can see it in sarcomas, you can see it even in carcinomas. But in MPNST you can see it quite often, and as I said, usually it's a rhabdomyosarcoma. And such a tumor is called malignant tritone tumor. So it's basically MPNST with a divergent differentiation. And we will leave MPNST and we will move to another tumor, which is less common, and it's a granular cell tumor, which you can see here. This is a beautiful example. Granular cell tumor, for a long time we didn't know that it's a tumor with neurogenic differentiation. So that's why we called it granular cell tumor, because we didn't know what it is. So we just called it according to the appearance, or according to the histological appearance of the cells, which are granular, as I will describe in a minute. So for a long time we didn't know what it is, what is the origin of the cells. But now we know that it's a tumor that shows a neurogenic differentiation, and the most of the cases is benign. So usually it's a benign tumor, but the malignant cases exist, but they are quite rare. They are quite rare, but they exist. So it's good to pay attention for the cytology of the cells and for the architecture. But usually it's a benign lesion. Again, it can be found basically anywhere in our body, but the typical localization is skin. So usually it's in the skin. Sometimes you can see it in gastrointestinal tract, especially the proximal part, oral cavity, tongue, specifically, especially the tongue. It's another typical localization, tongue, or it can be esophageal mucosa. And here we've got an example on the skin. So here you can see the skin excision with the subcutaneous tissue, dermis, and in the middle of the excision you can see a quite large tumor. And how does it look like? I said that the tumor is called granular cell tumor. So the cells look like that. The tumor consists of quite big oval cells with abundant eosinophilic cytoplasm that has a striking granular appearance, hence the name granular cell tumors. So there are multiple granules in the cytoplasm of the cells, which gave the tumor its name. The nuclei are smaller, they are quite dark, they can be even pycnotic. And the cells grow in a solid fashion. They form solid sheets, or they can form solid nodules. Sometimes you can have a problem to appreciate the boundaries of the cells, the membranes of the cells. So this is how granular cell tumor looks like. Large oval cells with abundant eosinophilic cytoplasm that contains multiple granules. That's why we call it granular cell tumor. The nuclei are darker, sometimes even pycnotic, and the neoplastic cells grow in solid sheets, or they can form solid nodules. So this is a granular cell tumor, and as I said, in most of the cases it's just a benign lesion. However, look at the epidermis. Look how ugly it is. The epidermis, well, first of all, there is a small erosion, there is a crust of hyperkeratosis and parakeratosis with numerous neutrophils, maybe caused by scratching, I don't know. But look at the epidermis. Look how thick the epidermis is. There is a huge acanthosis of the epidermis, there's a hyperplasia of the epidermis. And look how wild the epidermis looks like, with those islands or processes that goes deep into the tumor, and there are numerous keratin pearls, numerous keratin horns. It can be quite worrisome picture, this hyperplasia of the epidermis. But don't be confused, it's not carcinoma, it's not a malignant. It's just the reactive process, because the tumor can induce, and very often induces, such a big hyperplasia of the epithelium that covers the tumor. So this is just a reactive hyperplasia of the epidermis. This is not a malignant, it's just a reactive hyperplasia, and it's quite typical feature for a granular cell tumor. The granular cell tumor often induce this. So you can see it in the epidermis that covers the tumor. You can see it in the squamous epithelium, in the esophageal mucosa, or in the tongue that covers the tumor in these regions. So this is quite typical for granular cell tumor. And the tumor itself, it doesn't need to be so big, like we can see here. Very often it's a small lesion, and the neoplastic cells can be quite pale, and you can very easily miss them, or you can misdiagnose them as macrophages. So sometimes you can see some small lesion in the mucosa that looks just like the cluster of macrophages, or you won't see it at all, but the only thing that you can see is this extremely hyperplastic squamous epithelium on the surface. So sometimes these lesions are misdiagnosed as a squamous cell carcinoma. But don't be confused with that. This is not a squamous cell carcinoma. Even if this looks wild, this is just the reactive process. It's just the hyperplasia of the epidermis, and the tumor is beneath. So it's good to pay attention for that. And now let's move to the pediatric tumor, which is neuroblastoma. So what it is, first of all, sorry for the quality of the image, it's not sharp enough, but I think we will be able to describe it even in this picture. Neuroblastoma. Neuroblastoma is a malignant tumor. It's a very immature malignant tumor that differentiates towards neuroblasts of the sympathetic ganglia, of the sympathetic nervous system. It's a typical pediatric tumor. In pediatric age, it's one of the most common tumors, most common malignant tumors. And as I said, it consists of neuroblasts that, or the cells that differentiate towards neuroblast of the sympathetic ganglia. So it's usually situated in the localization when the sympathetic nervous system normally is. So usually you can find this tumor in retroperitoneum, you can see it in mediastinum, especially dorsal mediastinum, but the most common localization are the adrenals, because the adrenal medulla, embryologically, it's a vegetative ganglion as well. So as I said, it's a malignant tumor, it's typical for pediatric age, and it can be quite aggressive. It can grow very quickly, but the response to chemo is quite good, so the prognosis of those patients is not bad. And how does it look like? I said it's a neuroblastoma, so it consists of very immature neuroblasts. And as you can see just small round cells, and you would have a problem to say what is the differentiation of those cells. It would be very problematic to tell without immunohistochemistry. This tumor belongs to the group of so-called small blue round cells tumors, which means that it's a group of the tumors that consist of those very immature cells that looks like blasts, basically. And maybe you remember from histology that a blast is a typical example of the cell that produces proteins for its own purpose. And this cell looks like this. The cell is usually small, it's oval, and it has a small amount of cytoplasm. Because the cell is immature, there is just a small amount of organelles, but the cytoplasm, you don't see it very well here because because this picture is too bright. But usually the cytoplasm is rather basophilic. It's not eosinophilic, but it's more basophilic, because as I said, it doesn't contain many organelles, but it contains a lot of ribosomes, because because the cell needs a lot of proteins for its own purpose. So the proteosynthesis, it's quite striking here. That's why the cell needs a lot of ribosomes, and ribosomes are basophilic in HNE. So that's why the cells have a basophilic cytoplasm, but just a small amount of it. And the nuclei, they are oval, and they are quite big, and they are pale, because the cell is very active, and it needs a lot of chromatin, a lot of euchromatin. So I just described blast. I just described a blast, and those tumors that belong to the group of tumors from small blue round cells, they basically look like this, very immature cells that looks like blasts basically. And a lot of tumors belong to this group. It can be neuroblastoma, it can be Wilms tumor, nephroblastoma, it can be lymphoma, it can be embryonal rhabdomyosarcoma. So a lot of tumors, and especially a lot of malignant tumors, can look like this. And usually you need immunohistochemistry to differentiate those tumors, because in basic staining in H&E it looks like this, just the immature cells. But sometimes we can see some features that can point at specific diagnosis. And in case of neuroblastoma, sometimes you can see features that indicate neural differentiation. First of all, you can see rosettes. You can see rosettes, which means that the cells form, let's say, circles. And in the center of the circle, you don't see nuclei. You see just the neuropil. You don't see the neuropil very well here because, as I said, the picture is not sharp enough. But here is the region without nuclei, which will be full of cellular processes. It will be full of neuropil, and the nuclei form a rosette on the periphery, or a circle or a ring on the periphery of the rosette. So these rosettes, they are quite typical, and if you see them, you can guess that you deal with some neurogenic immature tumor. In case of neuroblastoma, these rosettes are called Homer-Wright rosettes. And also, you can see that this tumor is malignant. So the cells are not only immature, but they are also atypical. The nuclei have different sizes and shapes. Sometimes you can see bizarre looking cells even. And again, you should be able to find a lot of mitosis and sometimes even necrosis. So this is how neuroblastoma looks like. It's a very immature tumor. The cells are basically on the level of blasts, but they also show some features of malignancy, and sometimes you can appreciate some features that can point you to the diagnosis of a neurogenic tumor. So sometimes you can see neuropil and Homer-Wright rosettes. So that's how neuroblastoma looks like. As I said, it's a typical pediatric tumor, one of the most common ones. It can be quite aggressive, but also the response to chemotherapy is quite good. Also, the neuroblastoma has one typical feature. It shows a tendency to spontaneous regression. So sometimes the tumor can regress. Sometimes it can even completely regress. And also, it can differentiate. It can differentiate to tumor that we call ganglioneuroma. And ganglioneuroma is considered a benign tumor. So sometimes the neuroblastoma can differentiate to benign tumor, which we called ganglioneuroma. The differentiation can be sporadic, or it can be induced by chemotherapy. Here you can see mitosis, for example. So this differentiation can be sporadic, or it can be induced by chemotherapy. And that benign counterpart of the neuroblastoma is called ganglioneuroma. And sometimes you can see something in the middle. So sometimes you can see a tumor, and in some regions the tumor consists of a neuroblastoma, and in other regions it consists of ganglioneuroma. And such a tumor is called ganglioneuroblastoma. So it's something in the middle. And it's still malignant. It's still considered malignant because there is still a part of neuroblastoma inside the tumor. But if the tumor consists of pure ganglioneuroma, we will call it ganglioneuroma, and we will consider it to be benign, which we will describe in a minute. And you can see it here. So this nodule. this nodule, this is ganglioneuroma. So as I said, ganglioneuroma, it can appear sporadically. It can appear sporadically, like de novo, I mean. It can appear de novo, it can appear as a progression from neuroblastoma. So the both ways are possible. And it looks like this. You hear the term ganglioneuroma. And it means that this tumor is considered benign and it shows differentiation towards vegetative ganglia. So it tries to look like vegetative ganglion. It tries to look like ganglion. And because of that, you can appreciate the structures that are normally a part of the vegetative ganglion. You can see the majority of the tumor consists of elongated cells that shows a differentiation towards Schwann cells. So again, they are spindle-shaped, elongated. Sometimes they can be also wavy. And again, they show no signs of atypia, no increased mitotic activity. And you can see some neuropil in between. So if you would see just this, you could very easily mistaken this tumor for schwannoma or neurofibroma. But the diagnosis of ganglioneuroma is made because of this. This is the other component of the tumor, and here you can see the cells that shows differentiation towards ganglion cells, as you can see in normal ganglion. So here you can see those big oval cells with abundant eosinophilic cytoplasm, and the nuclei are usually large, bright, with a prominent nucleolus. So they basically look like normal ganglion cells. And if you see this combination of smaller elongated cells that looks like Schwann cells, and also those big cells that looks like ganglion cells, big oval cells with abundant eosinophilic cytoplasm, big pale nucleus and prominent nucleolus, this is ganglioneuroma. Typical localization for ganglioneuroma is retroperitoneum, dorsal mediastinum, sacral region. So basically the localization where normal vegetative ganglia can be found. And sometimes you can even mistaken them for that, because imagine the situation that the patient has a tumor in retroperitoneum, for example, and the clinician takes a small sample. He or she performs a needle biopsy, for example, and within this small sample you see something like this. So you see those elongated cells and those big ganglion cells, and you are not sure, well, is it a real tumor or is it just a normal physiological ganglion? And it means that the clinician just didn't sample the tumor. So sometimes, especially within the limited small biopsies, it can be quite difficult to tell whether this is ganglioneuroma or just a normal ganglion. But in normal ganglion, the architecture is more organoid, and in tumor, in ganglioneuroma, everything is more haphazard because it's a neoplasia. So in ganglioneuroma, all those components are more haphazard, and in vegetative ganglion they are more organoid. And as I said, this is a benign lesion. Okay, and the last neoplasia that I will show you is called paraganglioma or pheochromocytoma, which is a synonym, and I will describe it in a minute. Basically, paraganglioma is a tumor that differentiates towards paraganglia. If I want to be more specific, the cells in this tumor differentiate towards pheochromocytoblasts, which are the cells that subsequently differentiate towards chromaffin cells of the paraganglia and adrenal medulla. So that's why we call it paraganglioma. It's basically the second developmental line of the neural crest cells. The first developmental line is towards neuroblast of the autonomic nervous system, and the second line of development are those pheochromocytoblasts, which subsequently differentiate towards chromaffin cells of the adrenal medulla and paraganglia. And this tumor differentiates towards those pheochromocytoblasts. So the typical localization is, or we can usually find this tumor in the localizations that paraganglia normally are. So we can see it in the region of glomus corticum. We call it a tumor of glomus corticum. We can find it in the region of jugulotympanic paraganglia and so on. And very often we can see it also in adrenal medulla. And a paraganglioma that is localized in adrenal medulla is called pheochromocytoma. So the pheochromocytoma is just the topical variant of paraganglioma, but it's the same tumor. It's the same tumor, it's just the topical variant, it's basically a synonym. But generally speaking, we can find paraganglioma basically anywhere in our body. The biological behavior is very variable. The vast majority of the tumors behave in benign fashion, but some of them can be malignant, some of them can metastasize. And the problem is that you cannot guess it based on the histological appearance. Some of the tumors can be very atypical, the cells can be atypical, they can be even bizarre. You can see the things like necrosis, you can see the infiltrative margins, you can see even the vascular invasion. But it doesn't necessarily mean that the tumor will be malignant and that the tumor will be prone to metastasizing. But on the other hand, even the tumor that looks completely bland, that looks completely benign, you cannot exclude a possibility of metastatic spread. So that's the problem with this tumor, and that's why all the examples, all the tumors should be considered as a potential malignancy despite the histological appearance. So this is the important thing in paragangliomas, and it is said that the only definitive diagnosis of malignant variant of paraganglioma is the presence of metastasis. And how does it look like? Histologically, the cells or the tumor tries to resemble paraganglia. So the cells are quite big, they are large, they are oval or polygonal, they have eosinophilic cytoplasm and oval nuclei. You see that the cells are, usually they are not atypical, they are quite bland looking. But sometimes you can see atypical cells with bigger nuclei, with hyperchromatic nuclei. Sometimes the cell can be even bizarre looking. But as I said, it doesn't say anything about the biological behavior. You can see tumors that are diffusely atypical like this, but it doesn't necessarily mean that the tumor will be malignant. But on the other hand, you can see the tumors that are completely bland looking like this region, for example, but you can exclude the metastatic potential. So you cannot guess based on the histologic appearance. But generally speaking, the tumor consists of large oval cells with abundant eosinophilic cytoplasm and oval nuclei, and the cell grow in nests, in balls. And this histological pattern, which is very typical for paragangliomas, has a German name, which is Zellballen, which means in translation ball of the cell balls. On the periphery of those cell balls are smaller cells, which are smaller, elongated, they resemble something like Schwann cells, and usually you cannot appreciate them in H&E. Maybe this is one of those cells, but it can be also fibroblast, we don't know. And usually we need immunohistochemistry. And these cells are called sustentacular cells. And they are of neurogenic origin, and they are S100 positive because of that. Those huge cells would be negative. So those sustentacular cells, they are supportive cells for those cell ballen, and they are usually on the periphery of those cell walls. And usually you need to use immunohistochemistry to highlight them by S100 protein or antigen. So that's how paraganglioma looks like. So the large oval cells with abundant eosinophilic cytoplasm that grow in balls, and on the periphery of those balls you can appreciate smaller elongated cells. Usually you need immunohistochemistry to highlight them, and these smaller cells are supportive and they are called sustentacular cells. So that's how paraganglioma looks like. And again, be aware of the histological appearance, that the histology doesn't predict the biological behavior of the tumor. And the pheochromocytoma would be similar or even the same, because as I said, it's the same tumor, but just the name is different because it's a topical variant. It's good to know that those cells, especially in case of pheochromocytomas, they produce catecholamines. And the patients can have a lot of clinical symptoms because of that. Especially the hypertension, it can be very severe. It can have a rapid onset and a lot of other problems. So this is paraganglioma. And last but not least, I would like to show you one last lesion. And I say lesion, not a neoplasia, because this is not a neoplastic process. It's just a reactive hyperplastic process. But sometimes it can be mistaken for neoplasia, especially clinically, because especially in the clinical setting, it can be quite worrisome and very often excised, and by histology the correct diagnosis is made. And this is something that we call traumatic neuroma or amputational neuroma. Amputational neuroma, it was called because especially in previous times we saw it in the setting of amputations, but especially in these days, much more common clinical scenario is trauma or some other surgical procedure rather than amputation. This can develop in peripheral nerve that is damaged. If you cut the peripheral nerve, the distal part of the nerve will just degenerate by Wallerian degeneration, and the proximal part can sometimes undergo a hyperplasia. It can undergo a hyperplastic process and it can form a nodule. And clinically it can be worrisome because the clinician can think, well, I just cut away some tumor and now there is a bulk in this region, and I'm afraid that this is the recidive. This is the recurrence of the tumor and I need to excise it. So sometimes it can be clinically worrisome, but histologically, biologically, it's just a hyperplastic process. And because it doesn't come only in the setting of amputation, but it comes in the setting of, let's say, generally traumatization of the nerve. So it can be an injury, it can be some other surgical procedure. We should call it traumatic neuroma rather than amputational neuroma. So this particular case, for example, it was a patient that underwent cholecystectomy. The patient underwent cholecystectomy, and in the stop of the cystic duct, he developed this. He developed this nodule. So the surgeon excised it, and he wanted to know what it is. And in this picture, you can appreciate a central cavity. So again, the picture is not completely sharp, so sorry for that. But you can easily appreciate the central cavity, which is lined by columnar epithelium without any atypia. This is the biliary epithelium. And here you can see some proliferation of biliary glands in the wall of the duct. And you can see a lot of fibrosis, a lot of scarring, and some chronic inflammation. So this is the remnant of the cystic duct. But the real lesion is here. You can see some paler nodules, paler areas, and these are just hyperplastic nerve fibers. So these nodules, which are a little bit brighter than the surrounding stroma, these are hyperplastic nerve fibers as a part of traumatic neuroma. So again, these paler eye areas, these are just the hyperplastic nerve fibers, and this more eosinophilic part, these more eosinophilic regions in between, this is just a scar tissue. This is a fibrosis. So you can see that the proximal end of the dissected nerve, it underwent a hyperplastic process, and you can appreciate the hyperplastic nerve fibers with some scarring, with some fibrosis in between. And this is traumatic neuroma or amputational neuroma, and as I said, this is not a neoplasia, this is nothing malignant, it's just a hyperplastic reactive process. And it's good to know it, because as I said, clinically it can be worrisome, especially if the patient underwent a surgical procedure for malignancy and then in the next weeks the patient develops this. So it can be very worrisome, because the surgeon can be afraid that the patient has a recurrence of the malignancy. So that's all. Thank you for the attention, and see you later.